Hi, in this video we will read about unprovoked seizure from page number 3597 of Nelson's volume 2 and chapter number 33 seizures 633 seizures in childhood. Unprovoked seizures, history and examination. Evaluation of the first time seizure was discussed earlier in this chapter. It entails the stabilization of the patient of a child present during or shortly after the seizure. First we have to do what? We have to stabilize the child. A careful history and examination are done to accurately characterize the seizure, exclude acute intervenable causes and attempt to determine the underlying etiology of the seizure. Differential diagnosis. This involves the consideration of non-epileptic paroxysmal events. Fine, we have to consider them also, and determination of the seizure type are as classified by the ILAE system, and consideration of the potential underlying etiologies. Some seizure might begin with auras, which are sensory experiences reported by the patient and are not observed externally. Okay, moving ahead. Motor seizures can be tonic, clonic, myoclonic, atonic or aesthetic. Aesthetic seizures often follow myoclonic seizures and cause a momentary loss of tone with a sudden fall. Okay. And atonic seizures, on the other hand, are usually longer and the loss of tone often develops more slowly. Okay. So what is happening in the there is something called as the aesthetic seizures, in which there is loss of tone with a sudden fall. But in atonic seizures, there is loss of tone, but it develops slowly. Okay. Sometimes it is difficult to distinguish among the tonic, myoclonic, atonic or aesthetic seizures based on the history alone when the family reports only that the patient falls. In such cases, the seizures may be described as a drop attack. Okay. When we are not able to confirm which type of seizure it is and the patient is only giving the history of fall, then we can term it as the drop attack. Loss of tone or the myoclonus in only the neck muscles results in the milder seizure referred to as the head drop. Tonic, clonic, myoclonic or atonic seizures can be focal, including one limb or one side only. Focal with the secondary generalization, okay, or primary generalized. Epileptic spasm or the axial spasm, these terms being preferred over the infantile spasm because the spasm can occur beyond the infancy also. Consists of flexion or extension of the truncal and extremity musculature that is sustained for 1 to 2 seconds, shorter than the duration seen in the tonic seizures, which last longer than 2 seconds. Okay, so there is something called as this epileptic spasm or the axial spasm, in which there can be there is just increase in the tone. It can consist of flexion or extension of the truncal and the extremity musculature, which is only for 1 to 2 seconds. It is shorter than the duration seen in the tonic seizures. That's why there is another different term. But in tonic seizure, the spasm or the increase in the tone lasts longer than 2 seconds. Focal, motor clonic or the myoclonic seizure that persists for days, months or even longer are termed as the epilepsia partialis continua. So what is epilepsia partialis continua? It is focal motor clonic or myoclonic seizure which persists for many days or even months or sometimes even longer than that. Now coming to the absent seizures, are generalized seizures consisting of staring, unresponsiveness and eye flutter. Okay, what is happening? There is vacant staring, there is unresponsiveness and there is eye flutter which lasts for a few seconds. Typical absences are associated with 3 Hz spike and slow wave discharges and a childhood absence epilepsy, which is a good prognosis. This one is the type A of absent seizures. Now there is something called as the atypical absences also are associated with 1 to 2 Hz spike and slow wave discharges with the head atonia and myoclonus during the seizures. In the atypical ones, there can be head atonia and myoclonus during the seizures. Okay. They occur in the Lennox-Gastaut syndrome and similar syndromes which have poor prognosis. This atypical absences occur in these ones. Juvenile absences are similar to the absences but are associated with 4 to 5 Hz spike. Okay, this is important. Then in juvenile, which is also known as the juvenile myoclonic epilepsy or the JANZ, Jan syndrome, and from Jan's, there are 4 to hertz because there are 4 letters, right? So there is 4 to 5 hertz spike and slow wave discharge and often occur in the juvenile myoclonic epilepsy. Seizure type and the other EEG and clinical manifestation determine the type of epilepsy syndrome with which a particular patient is afflicted. A family history of certain forms of epilepsy, such as benign familial neonatal seizures, can suggest specific epilepsy syndrome. More often, however, different members of the family with a positive history of epilepsy have different types of epilepsy. Specific findings on a physical exam may point to an underlying disorder causing the seizure, such as tuberous sclerosis or the Sturge-Weber syndrome or neurofibromatosis or other brain malformations. Long-term approach to the patient and the additional testing. The approach to the patient with epilepsy is based on the diagnostic scheme proposed by ILAE task force on classification and terminology and presented in this table. Most epilepsy syndromes are potentially caused by any one of the multiple underlying or still undetermined etiologies. However, in addition, there are many epilepsy syndromes that are associated with the specific gene mutations. Different pathogenic variants of the same gene can result in the different epilepsy syndromes, whereas variants of the different gene can cause the same epilepsy syndrome. Phenotype. The clinical use of gene testing in the diagnosis and management of the childhood epilepsy is indicated in patients manifesting specific underlying malformation or metabolic or degenerative disorder. Patients with the severe epilepsy syndrome, such as the West and the Dravet syndrome, and progressive myoclonic epilepsies, and patients with the syndromes of Mendelian inheritance. So in those only there is use of genetic testing. Gene testing is indicated in epilepsy, encephalopathy syndromes, and in patients with the organ involvement like the hepatic, muscle, cardiac or intestinal, and in the atypical phenotypes. In patients with drug-resistant epilepsy or in infants with the new onset epilepsy in whom the initial testing did not reveal any underlying etiology, a full metabolic workup including the amino acids, organic acids, biotinidase, CSF studies is needed. Okay. In whom all these workup is needed? In patients with drug-resistant epilepsy or in infants with new onset epilepsy. Fine. And on initial testing we did not find anything, and so we need a full metabolic workup including amino acids and these organic acids and biotinidase and CSF studies. Additional testing can include, depending on the case, some or most of the following. Okay, fine. These are the additional testing. First one is the measurement of the serum lactate, pyruvate, acyl carnitine profile, creatine, very long chain fatty acids, ammonia, and guanidine acetic acid. Okay, so this was one of the additional tests. And the other one include blood in the serum sometimes need to be tested by white blood cells lysosomal enzyme for what? White blood cell WBC lysosomal enzymes, serum coenzyme Q levels, and the serum copper and ceruloplasmin levels for the Menkes syndrome. Fine. Or there can be serum immune isoelectric focusing on the gene panels is performed for the carbohydrate deficient transferrin in disorders of glycosylation. CSF glucose testing looks for glucose transporter deficiency, and the CSF can be examined for cells and proteins for para-infections, infectious and post-infectious syndrome, and for the Aicardi-Goutieres syndrome, which shows cerebral calcification, this syndrome, and has a specific gene defect test available. Okay, so these are the things that we are now reading. They are all additional tests in which in the initial testing we did not find anything, but these are not responding. The patients are drug resistant, and infants with a new onset epilepsy syndrome, infants less than 1 year, in those we are doing these additional testing. First, fine. First, we did the serum lactate, pyruvate, acyl carnitine profile, creatinine, and very long chain fatty acids, ammonia, and all. Then we did the uh, WBC, lysosomal enzyme levels, and the serum coenzyme Q levels, then copper and ceruloplasmin for Menkes syndrome. And then now we are doing the immune isoelectric focusing. And there is something called as the Aicardi-Gautier syndrome, in which there are cerebral calcifications also present. Other laboratory studies include CSF immunoglobulin, IgG index, NMDA receptor, and the other autoimmune encephalitis associated antibodies, as well as measles titer in the serum and the CSF. CSF tests can also confirm, with the appropriate clinical setup, the diagnosis of cerebral folate deficiency, pyridoxine dependency, pyridoxal 5-phosphate dependency, mitochondrial disorders, non-ketotic hyperglycemia, neopterin-biopterin metabolism disorders, adenyl succinate lyase deficiency, and the neurotransmitter deficiencies. In infants who do not respond immediately to anti-epileptic therapy, vitamin B6, how much 100 mg intravenously is given as therapeutic trial to help diagnose the pyridoxine responsive seizures. This is really important. In infants who do not respond immediately to anti-epileptic therapy, what we give? We give vitamin B6 in the dose of 100 mg IV as a therapeutic trial to help diagnose the pyridoxine responsive seizures, with precaution to guard against the possible apnea. So there is a risk of apnea, okay. The trial is best done with a continuous EEG monitoring, including a pre-administration baseline recording period. Before the vitamin B6 trial, pipacolic acid level in the serum, urine, or CSF alpha aminoadipic acid semialdehyde level should be drawn, because they are often elevated in this rare syndrome, and the therapeutic trial result may not be definitive. Okay, so in this children in whom we were doing this therapeutic trial of vitamin B6, we need to test some levels. Before vitamin B6 trial, what we need to do? We need to check the levels of pipacolic acid level and serum, urine, or CSF alpha aminoadipic acid semialdehyde levels. Okay, because they are often elevated. Okay, some patients are pyridoxal phosphate rather than pyridoxine dependent. Patients with the cerebral folate deficiency can also have intractable seizures. Okay, patients with what? Cerebral folate deficiency can also have intractable seizures. Thus, trial of pyridoxal phosphate given orally up to 50 mg per kg per day given every 6 hours, and folinic acid 2.5 to 5 mg twice a day if needed, can titrate up to maximum dose of 8 mg per kg per day. Over several weeks can help diagnose these rare disorders, while one is waiting for the definitive diagnosis from the CSF or genetic testing. Okay, so while waiting for the definitive diagnosis from CSF or any genetic testing, we can do what? We can do trials of this pyridoxal phosphate up to a dose of 50 mg per kg per day given every 6 hours, and folinic acid of 2.5 to 5 mg twice a day if needed, and can titrate up to maximum of 8 mg per kg also. Certain EEG changes, such as the continuous spike and slow wave seizure activity and burst suppression patterns, may also suggest these vitamin responsive syndromes. Okay, what will be seen in this vitamin responsive syndrome? There will be burst suppression patterns. Now coming to this, urine may also be needed to test for the urinary sulfides, indicating molybdenum cofactor deficiency, and for the oligosaccharides and mucopolysaccharides also. MR spectroscopy can be performed for the lactate and creatine peaks to rule out the mitochondrial disease and creatine transporter deficiency. Gene testing to look for the specific disorders can manifest with the seizure, including the SCN1A pathogenic variant in the Dravet syndrome, ARX gene for the West syndrome in males, ARX gene, okay, and MECP2 and CDKL5 and the procatharin 19 for the Rett syndrome. What is seen in the Rett syndrome? MECP2 and CDKL5 and procatharin 19. And similar presentations syntaxin binding protein for the Ohtahara syndrome and the polymerase G for the West syndrome and the other seizures in the infants. Gene testing can also be performed for other dysmorphic or metabolic syndromes. Muscle biopsy can be performed for the mitochondrial DNA and the oxidative enzymes, as well as coenzyme Q10 levels, and skin biopsy for the inclusion body seen in the neuronal ceroid lipofusions and Lafora body disease. Genetic panels are available that include multiple genes that can cause epilepsy. So in 8th part, what we did was muscle biopsy for what? Mitochondrial DNA and oxidative enzymes, as well as this coenzyme Q10 levels, and skin biopsy also for what? Inclusion bodies, which are seen in what? Neuronal ceroid lipofuscinosis and this Lafora body. These diseases I'm hearing for the first time. These Lafora body disease. Okay, coming to the next one. Genetic panels are available that include multiple genes and that can cause epilepsy at specific ages. Whole exome or genome sequencing is also available. The availability of these gene panels, particularly one that can test for the amiably treatable conditions such as the vitamin B6 dependent epilepsy and the rapid turnaround time, have replaced the need for many of the tests listed in the point 1 to 9. MRI should be performed to identify the congenital disorders like the cortical dysplasia, lysencephaly, schizencephaly, calcifications, focal lesions in the basal ganglia, and myelinization disorders like the acute disseminated encephalomyelitis and the leukodystrophies. MRI may identify specific disorders such as the posterior reversible encephalopathy syndrome, that is the PRES, and the stroke, mitochondrial encephalopathy, lactic acidosis, and the stroke-like episodes that is the MELAS. So stroke caused by these MELAS can also be identified in the MRI. MELAS is what? Mitochondrial encephalopathy, lactic acidosis, and stroke-like episodes. Let's read that again. Mitochondrial encephalopathy, lactic acidosis, and then stroke-like episodes. Rasmussen encephalitis, tumor, cerebral edema, hemorrhage, or venous thrombosis. It should also be noted that the seizures alone may cause non-specific, non-diagnostic transient MRI abnormalities. These may include transient grey matter and subcortical white matter signals or transient hippocampal and temporal lobe abnormalities also. These abnormalities can alone be caused by seizures. So these were the rare diseases which are not routinely done in patients with seizures, but if we are not able to find the cause, then these tests can be thought of doing. Okay. Most patients do not require an extensive evaluation. The pace and the extent of the workup must depend on the clinical epileptic and non-epileptic features, the family and the antecedent personal history of the patient, the medication responsiveness of the seizure, and likelihood of identifying a treatable condition, and the wishes and the need of the family to assign a specific diagnosis to the child's illness. So this was all about unprovoked seizure. In the next video, we will read about the focal seizure and related epilepsy syndromes. Thank you.